Sorry, am I unmuted? Great, thank you, James. So our first organ system working group is hematology, and Dr. Angela Dispenzieri will be presenting on behalf of that working group. I'd like to pause and first hear from one of the working groups members, Mackenzie Bueker, to give her input as a patient, thinking about how different endpoints here might impact, you know, the patient perspective. Mackenzie.
Hi, everyone. My name is Mackenzie. I am 27 years old, and I was diagnosed with AL amyloidosis without organ involvement at the age of 23. As a member of the hematology working group, there are two main things that I would like to touch on regarding the patient experience. The first is the toxicity of treatment. It's important to keep in mind that many treatments available to patients come with a burden of toxicity and side effects that can be debilitating, some lasting far beyond the end of treatment. For example, some of the treatments I've undergone have required me to potentially sacrifice my fertility in hopes of a complete response. And as a 23-year-old, this is a tragic thought. In addition, other patients live with immense pain or inability to perform simple activities of daily living. As a result, the toll that treatments take on their bodies. It's a sacrifice we must make to live longer, but we dream of a day where the burden of treatment is far less costly. My second and final point is the need for more treatment options. The last few years have been incredible for drug development. Vyndamax, Onpattro, Tegsedi for ATTR, and most recently Darzalex for AL, but we must continue this advancement. While there are options for patients, there simply aren't enough. Some treatments don't work for some patients, some treatments don't work forever, and some patients aren't eligible for certain treatments. As patients, we move on to the next treatment when one stops working, and as a result, we cut our treatment options that much shorter. It feels like approaching the end of a rope you're so desperately hanging on to. But with that said, I greatly appreciate all of the work everyone has done for this community, and thank you for working to make our futures brighter.
And thank you, Mackenzie, so much for that and for being an important member of this group. Appreciated.
Thank you so much.
Thank you. Dr. Dispenzieri, I will leave it to you to talk about the findings of this group.
Okay, you're not seeing it, are you? Let's see.
We can now see you.
Yeah, stop share. Let's try a new share. All right, so I want to share screen 1. And sorry, folks. Okay, do you see that?
Yep. Yes.
Okay, I apologize. So I have the privilege of talking about prioritized hematologic response endpoints. And this is the work of a number of people. We had a number of meetings and went over a lot of endpoints, and then we shared it with other members within the amyloid community and got some input there. So this is definitely a work in progress and in flux, but I think we have some really important points to share for discussion. So challenges with hematologic endpoints. Despite existing data showing strong relationships between amyloid complete response and overall survival, amyloid complete response has not been considered adequate as primary endpoint for full approval. Now, as mentioned, we're delighted and fortunate to know that Andromeda amyloid CR was sufficient for accelerated approval for Darzalex, but continued approval is dependent upon further verification of long-term outcomes. Most often within the cancer space, with the myeloma space, progression-free survival and overall survival have been the registrational endpoints. Now, progression-free survival is dependent on progression events, but in the existing amyloid response criteria, progression is the weakest definition. It's an old definition that's due for updating. And then overall survival is not really a feasible endpoint for most AL studies. And what I'm showing you here, the red line are patients who would potentially be eligible for trials. They have a heart blood test called the NT-proBNP, less than 8,500, whereas the blue line are those patients with the very, very high NT-proBNP and are actually excluded from trials. And so you can see that, again, with a 60% survival rate at 5 years, and that's not accounting for really effective therapies and getting complete response, you can see it would take potentially years and years to use overall survival as an endpoint to get drugs. So the goal of this presentation is to discuss endpoints that can be validated in data sets. So hematologic trial endpoints is about shared, this is a disease of plasma cells. They make light chains. Those light chains can be toxic. They make fibrils, amyloid fibrils that are toxic. But in the only thing we can directly measure at this point, at least in the US and much of the world, is really those plasma cells and the light chains. And that gets us to hematologic parameters. Of course, we care tremendously about what's going on in all the vital organs because that's what results in quality of life and overall survival. But those at present are indirect measures. So everything that comes thereafter really is dependent on having adequate and satisfactory and robust hematologic response measures. So in terms of endpoints, we came up with some ideas. If you look at the patients who are the ones who are going on most clinical trials at this point, the patients without the very, very severe cardiac involvement, a primary endpoint would be the amyloid complete response, and that has worked for Andromeda. But the question is, what should that key secondary endpoint be? And so the major organ deterioration, progression-free survival was defined by investigators in the Andromeda trial and Janssen. And essentially it was defined as progression-free survival, any hematologic progression-free survival event, and then sort of major end organ damage like dialysis, kidney transplant, very severe congestive heart failure, needing heart transplant, devices, and of course, death would be an endpoint for that. So that's one potential definition. Another one that we came up with was this notion of a hematologic failure-free survival, which is progression-free survival, but also counts a lack of adequate response at a pre-specified time point, and using those as what are considered failure events. And it's very similar to what Andromeda has used behind the scenes for the MOD EFS. And we'll talk in greater detail about that next, after we get through this slide. For the very, very sick patients with the very severe heart, overall survival is a potential primary endpoint, with then perhaps the amyloid complete response as a key secondary, though one could argue plopping that ACR into the primary endpoint box is a potential consideration. There are many other secondary endpoints. We're not going to go into those. In terms of patients with relapse refractory disease, so 1 to 3 prior regimens, not that heavily pretreated, again, very similar to what we would like to see in the newly diagnosed patients. For those who are multiply relapsed, perhaps using a primary endpoint that's not quite as stringent, so that we don't miss access to drugs that do help, but that may not be a complete home run. And then again, using one of these key secondary endpoints that needs to be better elaborated upon and elucidated. And then a number of other secondary endpoints to study. So what about hematologic progression? This is really the most important thing that we are going to talk about. It needs to be attainable but valid, and it goes hand in hand with organ status. So what you see here is, so in 2005 and 2012, there were consensus statements from amyloid community on how we would define both progression and response. And so this is the part of the progression story, relapse going, having a positive immunofixation or an abnormal free light chain, as long as the involved free light chain doubles. But this is the problematic part. So the notion of using the DFLC, a 50% increase, that part's fine, but with a minimum, getting to a minimum value of 100 milligrams per liter. This is what we struggle with. And the reason for that is that we know just from general practice, but to put some data on the page, in a series examining the status of AL patients treated with second-line therapy, the group from Pavia highlighted that the median DFLC of patients getting second-line therapy was 55 milligram per liter. About half of what we consider a progression event. And so expecting physicians, investigators to wait to satisfy that criterion, it's just not going to happen. And so a lot of patients end up just being pulled off of the study. They end up being censor events as opposed to progression events. And those progression events or those negative events are what counted to really power a study to show that a drug is working or not working and using it as a comparator. And so you can see that that's a big trouble. Even from our institution, which is dealing with patients that were getting second-line therapy post-transplant, and again, looking back when we had very many less effective therapies, more than a third had a DFLC greater than, or I'm sorry, less than 50 when new therapy was started. So again, there's a lot of information here on this slide, but I really just want to focus on this part here, progression. As a group, we started talking about other potential opportunities for criteria, as long as one's addressing response and progression criteria, but I'm not going to belabor that because those aren't really primary endpoints. And so I'd like to focus a little bit here. And again, what's in black on the slide is what existed before, and then the sort of green font is sort of potential ideas. And again, this is not codified. This all needs to be validated in data sets, hopefully provided to us by industry, that they can look at these things. But the notion of having a DFLC going up only to 40 as an idea of a progression from CR and from VGPR is sort of a hallmark of that. And then also using a DFLC 25% increase from confirmed nadir from the partial response category. And then again, for the rare patient who has an M spike, that going up, that would also suffice. But the other concept here is that of failures. And so again, everybody would admit that a progression as defined above is a failure of the drug, of the therapy. But the idea, capturing the sense of urgency in patients with amyloid, that the idea of not getting to, in a newly diagnosed patient, not making it to a very good partial response or better, or not getting to a DFLC of 40 or less after a pre-specified numbers of cycles or months, is something that makes physicians want to take their patients and leave the trial because they want to do better. And so recognizing that as a true parameter or criteria would be important. And then also less than a complete response and a lack of organ response at a pre-specified time point would be really measures to I think, improve how patients flow through clinical trials. And again, just a little bit of data. This is also from the Pavia group, where they showed among patients who respond to first-line therapy, but in whom they deemed it inadequate, just kind of in their database. And they show that here you have patients, 196 patients out of almost 900 patients total, but 196 of them had a baseline DFLC of 484. And then at their best response, they got down to 111, so that's pretty close to the 100. They said, not good enough, and they basically started additional therapy. And so, again, our response criteria really need to reflect what is happening in the real world so that then patients are getting best standard of care and clinicians feel comfortable keeping patients on study. Introduction of failure events, so points of clarification and important points. Introduction of failure events, which include inadequate hematologic response at pre-specified time point, is important, and perhaps a new survival modeling would be standard, the hematologic failure-free survival, which is different from time to next therapy, because time to next therapy isn't predefined. It's a description of something that happened. You're trying to catch up for events that have already occurred on some level. And then conceivably refractory disease, could be defined or just specified that it's less than a partial response, and it could be broken down as a descriptive, but that's sort of just a possibility. Other points, I think, really codifying that confirmed response is required for every response category. And this is largely for analytical purposes. What you can see is that patients, these assays have variability, whether it's the immunofixation of the serum or the urine, the free light chain. And so the idea of even confirming it, just a separate draw, same day, just to make sure that it's not a true outlier would be an important concept. Confirming the nadir from which to calculate progression perhaps could be the average of the two lowest consecutive values. And then urine, it wasn't in the original 2012 Palladini criteria, but it snuck into the Comenzo paper in 2012. But so it's no longer a measurable hematologic response criteria. It's still required for documentation for immunofixation, but we're not documenting hematologic response or progression purely on the size of a urine M spike. So in terms of the progression and hematologic failure-free survival, questions that were asked of us, is the endpoint objective? Progression, I think, can be made very objective. The HFFS with predefined timeframes for failure decisions could also be objective, have meaningful thresholds, clinically relevant, certainly not yet validated in prospective trials, but this is what's happening in real life, and there's much in the literature reflecting this kind of activity. And so the natural history has been well described, and this will allow for analyses to validate progression definitions in existing clinical trials, and we can get endpoints quickly. And then the open questions are that we really do need to validate the details, but I think the concepts are key in what could be incorporated into a some kind of a composite response progression story. In terms of hematologic response, we know it predicts for organ response, progression-free survival, and overall survival. Again, it is what drives things. This is the important paper from 2012, where you can see in blue the CR patients do far better, or do better than the very good partial response patients, and better yet than the partial response patients and the patients who have no hematologic response. And again, you can see the hazard ratios here. Again, the best is the amyloid CR, but the risk of death increases as you have lower depth of response. And so that resulted in the 2012 consensus, and the things that are in red are changes from the 2005 definitions. But you can see that bone marrow was removed, and I think that that still is viable in terms of current activity. In the future, I think it will be included, but for the purposes of this exercise, I think it works very well at present without. The DFLC is definitely an important measure. And then, the partial response is still very important. Where do we go from here? We'll talk about on the next slides. I think there's potential room for improvement in the hematologic response, but immunofixation must stay as part of an amyloidosis complete response. There have been challenges in the inclusion of the free light chain ratio in the complete response definition. And the reason for that is that the free light chain ratio definition is ambiguous, and there's a clarification to be published in the Amyloid Journal to help out with that. But there are other issues about it that make it problematic, and that again, when you're doing something over something and one number gets really low, it makes the ratio very high, and so it gets a little bit confusing. And there are some studies that suggest that there are better ways of parsing the free light chain components, and that might be able to be validated in prospective treatment trial data sets. Again, potential room for improvement, allow for lower levels of measurable disease for free light chain eligibility, allow for M-spike only measurable disease in rare instances when the free light chain is not available. So what free light chain measure should be included in the definition of the amyloid CR? So this is the first study I'm showing you is from the Pavia group, and what they did is, so this is looking at the performance characteristics of a particular definition of amyloid complete response. So here is the standard current definition with the immunofixation of the serum and the urine being negative, and then also using the free light chain ratio as being normal. And you get this performance. They then did the same exercise, plucking out the free light chain ratio, but instead using the involved free light chain less than 20. And you can see the AUC there. And then the same exercise, again, plucking out the free light chain ratio, plucking out the involved free light chain, and putting in the DFLC. And you see the performance. So according to theirs, the confidence level intervals are overlapping, but this seems to do better. The Boston group also did a similar exercise. When they put the involved free light chain, now these are patients who underwent transplant, but that seemed to do a little bit better in terms of the AUC and the C statistic. The DFLC wasn't tested independent of these others, so hard to know, but it didn't compare, it was knocked out by the involved free light chain. And so perhaps that this may be the optimal free light chain measure to put into CR. Again, this works very, very well, the current definition. The idea is, can we do better? Will it allow for greater ease in clinical trials? So, the amyloid complete response definition of the future, again, nothing changing here in black, the immunofix negative. Do we keep it as is, or do we do something like using an involved free light chain being normal, and again, here is one possible definition, as long as the uninvolved is less than the upper limit of normal, otherwise go with the DFLC. Potential advantages with the DFLC, akin to an advantage with the ratio, is that renal failure can affect the involved free light chain. So moving on, the amyloid CR, the endpoint is definitely objective, meaningful, clinical relevance. Every study since the publication has demonstrated that amyloid CR and VGPR are prognostic and is associated with improved overall survival. One can look at this at 3 months, 6 months, and make a judgment about how a patient's doing. And the open question, is there room for improvement in the free light chain measure for the ACR? So in terms of the summary, amyloid complete response is a meaningful response, should be the primary endpoint for all newly diagnosed patient trials and for trials evaluating early relapse. Progression definition cannot remain the same. A DFLC of 100 mg per liter as a target progression number in the 21st century is untenable. It worked when we didn't have very good regimens and patients didn't get CRs and VGPRs, but now that therapies are so active, we need to do better. Allowing for failure events like inadequate response at a predefined time is essential. Linking these events to absence of organ response at a predefined time will facilitate trial conduct. Endpoints like bone marrow measurable residual disease will be of interest in the coming years, but the data are accumulating, and I think just right at this moment, it wouldn't be, a major endpoint. And then what we didn't address are challenges with other assays other than the binding site. Currently all of the work has been done with one brand assay, but Siemens and Savia assays are coming online. And so how will that really affect our criteria? And with that, I open to questions.
Thanks, Angela. There's a couple of questions that are over here. Maybe I can have Dr. Kurtz, who can come up to the panel. He asked this question, which I think it came up during our discussions too. So will a rise of DFLC from 32 to 41, would that be categorized as a progression from VGPR?
Yeah. I don't know if you want to answer it. I'm happy to answer it. Or
Go ahead.
you know, I mean, yes, you have to draw a line somewhere, and yeah, nothing is going to be perfect, and there are going to be, you know, areas where it's going to be kind of fuzzy, and we know, you know, the variability in the assay there is, and that may not be a true, you know, meaningful thing, but you have to draw a line in the sand somewhere. So that's where we're leaving it right now. And I think that testing it in prospective trial data sets will really define how big a problem that is or is not.
Maury, do you have anything else to add to that?
I think in practice, if someone's on a clinical trial and I had someone who was on maintenance drug X and their light chain rose from 32 to 41 milligrams per liter, which would be by these criteria, progression from VGPR, I'd be pretty angry if I was forced to discontinue therapy on the patient without some trend.
You know, well, a trend, and that's the whole idea of confirmation. So, you know, one thing.
41 then. So it's 32, 41, 41. I mean, it gets dicey because we're dealing with patients who may or may not be feeling well, but with these ground rules, it's like, yeah, you come off study, you cannot receive this drug anymore. It's awesome.
So what do you recommend, Maury? I mean,
I don't know. I mean, I wasn't part of the group, and it really requires a lot of thinking about if it's 20 to 30, does the increase have to be 20 or something like that? And
and I think
one of the things we discussed
complicated, and I don't have an answer in this real time, but I'm seeing this actually happening in the clinic, and it just raises a concern. And it may be that there is no solution for it, but people need to be aware that's a pretty minimal thing and would clearly fulfill progression criteria as defined. I mean, you have this where the minimum was 10 for progression. That makes a ton of sense to me, but that isn't applied to the VGPR category. It didn't have to be a minimum of 10. It's just a 25% increase and greater than 40.
Ashley, you wanted to say something, and then I can.
So one of the things we discussed quite a lot when we were talking about this was whether this needs to be interpreted in conjunction with the organ response for the patient. So somebody who has a VGPR with an organ response and persisting organ response is a very different patient from a patient where there is either minimal organ response or organ progression. So totally take your point on board, but I think the progression criteria do need not be just the heme criteria, but do need to be interpreted in conjunction with something else going on with their organ function.
And Maury, these definitions were sent around. I mean, you know, people have commented, I sent them around last week. And so, and I think for the purposes of this meeting, you know, the exact detail of what the number is I think that has to all be validated. And so, you know, think of it as a straw man. I think it's the concepts that we want to really, you know, not to ignore the details by any stretch, but I think for the purposes of this, it's really kind of conceptually what can go in to make for, you know, a good endpoint so that we can get drugs to patients as fast as possible. So, but I feel your pain for sure.
Angela, also, I think the key thing is what you previously mentioned is how often does this happen, right? I think we will never have a system that works for 100% of the people. And if it happens only in a small fraction, maybe it isn't that much of a problem.
You know, no, we saw it in the Takeda study, you know, people just going off of study because they did, you know, the physicians thought they progressed, but yet they're sensor events rather than progression events. And then that reduces your ability, it reduces your power. So again, we need to do better.
I think it's all the validation, right? Which brings up another question from Andrea Havasi here. She started asking about, you know, how soon will we be able to validate this? What's the timeline? How big a data set would we need to do this? And when do you think that's going to happen? So
Should we let Brendan answer that one? No.
Brendan answered it. That's another one which I'll bring up later.
Well, I mean, I think it absolutely needs validation. I mean, it just so happens we have one of the frontline trials, and however, it still is only 388 patients. So, I mean, we should definitely prioritize the endpoints that we want to take back and look back in Andromeda. I think another question that remains to be answered is how best to use the existing real world data sets, if you will, that are being built across centers, how to harmonize those with clinical trial data, because the data sets are not, they're very different. I think that has to be part of the effort, is how we harmonize the data sets. Because we have to be, I think there has to be a dose of pragmatism as we develop these, because we're not going to have a perfect data set.
Right. Any other comments? Otherwise, I just wanted to go to another question, Brendan, which you already answered, which I think is very relevant from Joel Buxbaum. Which the question is, if you are looking at lambda light chains, light chain stabilizers, their development pathway, how do we reconcile that with the light chain criteria that we are talking about, where we not anticipate a significant change there?
Let somebody else, I mean, I'm happy to answer, but I'd let other people talk. We've heard enough of my voice. Ashley, do you want to say anything, or?
I think that's a very important question when we move on to a different class of drugs, but I think this is a very different category of drugs from the drugs that we are currently using for treating our patients. And here we may not be able to use our standard hematological response criteria because the light chain levels might remain very similar or might even elevate if we're stabilizing the light chains. And we may have to use criteria which depend on the end organ function or a robust validated assay of the stabilization parameter itself, which is then correlated with either survival or end organ improvement. So I think when we get these drugs, we are going to be in a position to have to develop some new criteria or apply a different set of present criteria for them rather than the standard heme response criteria.
Right.
Again, I think in the most of the context, we would be doing something about the clone as well. It's unlikely that we would be doing something that's isolated only for the organ too, right?
Absolutely.
I'm sorry, I may have cut off somebody else who was going to answer something. No, okay. Let's jump on to the next question up here. So Raj, you had a question about what should be the lowest, for eligibility for entry into clinical trials, what should we be defining as our cutoff?
Yeah.
George, you want to take that on since we discussed that quite a bit?
Yeah, so again, a number of groups, Mayo, Germany, actually England, Italy, all have kind of looked at the 20 to 50, allowing a DFLC of 20 even in there, which is a little intimidating on some way because it's such a low level, but it certainly getting it down, because the 50 for many is not adequate. And I think again, that'll become way easier when we get to endpoints that include MRD and such. But yeah, so the 20 was out there.
Okay.
And I think, I guess, Angela, to your point too, it depends on what your endpoint too is, right? I think in a myeloma trial, for example, if the endpoint is a complete response, you really don't need any 0.5 for entry. You only need something that's detectable. So I think that's what you're trying to get at too, right? So.
Yeah. Just one clarification. So in case the endpoint is an amyloid CR, then in addition to that, the patient should also have an abnormal ratio, right? If we do the eligibility as DFLC of 20, in addition to that, they should have an abnormal ratio too, right? Otherwise, because in case the endpoint is a CR.
it's less necessary with the DFLC because if you have renal failure, they both go up, and so you end up with not actually a very high DFLC. That's the advantage of DFLC over IFL, over IFLC, because you're going to subtract two large numbers from each other and then end up with not a very abnormal, without a very large DFLC.
Okay, thank you.
Vaishali, maybe jump to you next. I know you had a couple of questions, particularly in terms of the confirmation and also maybe using different starting points for eligibility. Go ahead, Vaishali.
Right. So my first question is about the progression. And, I know that Angela suggested that even on the same day, or to confirm a hematologic response on the same day, in real world, the insurance is not going to pay for it. In clinical trial setting, I don't think they're going to allow that. I think, and what Maury suggested was obviously correct as well, that you have to show a trend to call it a progression. And the trend should it be few weeks apart? Should it be few months apart? Should it be a month apart? Should it be a week apart? I don't know, but I think that has to be placed in, that it has to be checked on 2 occasions, and probably not showing a trend, but to confirming that there is DFLC progression. And I think my second question was that currently the clinical trials for relapsed AL amyloidosis are enrolling patients with different eligibility criteria for DFLC. So DFLC of greater than 50, DFLC of greater than 45, SWOG 1702 had DFLC of greater than 40, melflufen clinical trial has DFLC of greater than 20 for enrollment criteria. So I think that is another thing that needs to be clarified and placed into account, because I think newly diagnosed trials are very different than relapse trials. I think the DFLC cutoff as a measurable cutoff has to be present. Thank you.
Thanks, Vaishali.
Great.
Any comments on Vaishali's statements?
No,
I agree with Vaishali that we need agreement, but I think it depends on the endpoint you're measuring. If your primary endpoint is CR, which is the goal of therapy, I don't think it's unreasonable to use the DFLC of 20. But if your endpoint includes understanding overall hematologic response, that such an eligibility might be problematic, I think. So in some ways it depends on the agent. Most agents in AL amyloidosis will be pretty heavily evaluated in myeloma. So the fact that the agent kills or doesn't kill plasma cells probably is already known. So I think you could do a trial of DFLC greater than 20, but I'm not sure that the regulators would like that. But I'm open to hear other thoughts.
Any comments from Drs. Gormley or Flores?
I guess I'll put one thing about the verifying progression. The notion of, and this is more sort of out of myeloma experience, you have a patient and, if you say you want to confirm progression and it's so obvious, I mean, it's not that it went from, 30 to, 41, it's that it went 30 to like 100. I mean, a huge jump, or 200. I mean, they really have exploded. Do you really want to get a confirmation wait like a month or 3 months? So that's kind of, now usually amyloid doesn't have that same type of biology, but occasionally, you can. So that's sort of, I mean, yes, nobody's going to do it the same day necessarily, but again, the hope of capturing that progression event and not just throwing it away because it didn't meet definition is sort of the intent there. But I wouldn't imagine that it would, be done on the same day typically. It would be more over time and getting a trend.
So Angela, I think I'm hearing support among the experts for adapting our current criteria, but it's just challenging, but I would love to hear from Dr. Gormley or Flores, a regulatory perspective on this. Would that be feasible?
Yes, definitely. I guess, I think this point has sort of been emphasized and underscored, and I just definitely want to get on the bandwagon as well to say, I think the really, that this is, really coming from a place of seeing inadequacies or some limitations in some of the current, criteria. But I think where we have to go in the future in defining, how do we make these decisions as to what cutoffs, et cetera, should be used, really has to be data driven. And, to the point that, Vishali sort of mentioned earlier was just, I think, the issue comes about, or it becomes really challenging then to aggregate all this data if we have different criteria here and different criteria there that are used in every single trial. And so to the extent possible that there can be consensus around, what criteria should be used for trial inclusion and criteria for assessment will allow us then to have more data ultimately when we're trying to answer these questions about what the appropriate criteria should be. So I guess I would encourage two things. One, that we need to look at this and figure out, what the data suggests, which direction we should move toward. But then also, in terms of standardizing across the board, how we conduct the clinical trials and in terms of eligibility criteria, endpoints, et cetera, so that ultimately, in the future, we can have a larger data set to rely on when we need to answer these questions going forward.
Thank you.
I agree also with Nicole. I think from the regulatory practice, I think what we have seen is a change in the definitions driven really by real life clinical practice. And what I don't want to see is clinical trial results that don't resemble the real life. And of course, it will have to be validated, but we have to start somewhere, and this is the start. And then definitions, perfect definitions, it's impossible, and it will also depend on the clinical trial, the specifics for that clinical trial. But in general, I think this proposal is reasonable and there's a rationale for that. There will always be exceptions and questions, no matter which definition we agree.
So do we have time for one more question here? I think maybe Laura, you have, and I think Nelson also brought up the same question in terms of the, how do we adapt these criteria in the context of renal failure?
It's a great
right. Yeah. So this did come up a second ago, and I guess I was thinking more about sort of absolute levels, but even using the FLC diff, I'm not sure we really know that the same criteria, because pre-life chains are cleared differentially based on kappa and lambda are cleared differentially, and so I'm, it's obviously this is an issue. Just wanted to put it out there.
And so in Ellie's paper, Ellie Muchtar's paper, he looked at above and below eGFR of 30, and but again, the numbers are small, and it all goes to the idea of validating these things because there aren't necessarily tons of patients, first of all, in clinical trials that are going to have the low eGFR, but really sort of aggregating data to understand the performance and test it in those sets, I think is definitely important, without a doubt. There was in the criteria, there was something that we had, where, the DFLC would be used, but we didn't specifically say renal failure. But yes, you're 100% right.
Thank you. Thanks.
So I think Vaishali was asking the question, is the Andromeda a big enough data set for us to answer these questions? And I think maybe, Brendan already alluded to this, saying that we really need to bring together all the different data sets, but just seeing if any other thoughts, Ashu or anyone else.
I agree. I think Andromeda is a great data set and it's prospective, but I think, as Brendan said, the total patient numbers, when you start breaking down into subgroups, will become very small. So we definitely need to use other data sets. I mean, we are quite lucky in amyloid that we've got some very large retrospective data sets, which are very well collected data from all our centers. And then we've got the AMN study, which is collecting data from a lot of European amyloid centers, where, again, retrospective data is collected and validated, which is presented at ASH. And that would be another very useful data set to be able to validate some of these questions that we raised up in this discussion today.
All right, I think that's all we had for questions here for mostly.
Would we though, so what I'm hearing again, I think, and sometimes you hear what you want to hear, you know, the devil is in the detail. And again, nobody saying any detail is going to be completely approved until it's validated. And, you know, so this is serving as a potential stepping off point for that. But I think in terms of this overall exercise of trying to find criteria to sort of think about for a composite or whatever, that idea that CR is key, maybe a little tweak the way it is, whatever, fine. And then as we come to a composite, and then also really finding a good way of thinking about other failures and acknowledging those patients so we don't lose them in terms of events, I think are sort of the high points without maybe 100% everybody agreeing on the details.
All right.
That's certainly what I heard from the discussion, Angela. So thank you very much for that great summary. I think it's interesting that, you know, where you started was that the current criteria are not doing us a great service because it's fueling the cycling of patients off therapies that might actually have more efficacy, which is exactly where Mackenzie started this session. So I think, thank you to this working group. I think you still have the devil in the details to be playing with. So I think your work is not totally over, but a huge thanks for putting the straw man down as a great starting point for evolving these. Thank you.